In the last 2 lessons in this course, we will discover the outcome measures that are guides for evidence-based medicine in clinical practice. Specifically, in this lesson, we will define outcomes, research factors that affect patient outcomes, the importance of measuring outcomes, and the selection of data to measure. The respiratory therapist has a vital role in the management of patients with chronic cardiopulmonary disease. The therapist in this role gathers both subjective and objective data, including medical history, a systems review, lab values, vitals such as blood pressure, heart rate and respiratory rate, oxygen saturation, heart and lung sounds, and rate of perceived exertion and dyspnea. In addition to biologic, functional, and physiological data, the therapist must also assess health-related quality of life, HRQL, measures. These include general health perceptions, physical, mental, social, and role functioning, and the impact of disease on the patient's life. Poor HRQL has been shown to reduce long-term survival following a cardiac event or with a chronic pulmonary disease. Rehabilitation programs have been linked to increased exercise capacity and physiologic response to exercise, improved quality of life, decreased symptoms, and decreased anxiety and depression. In fact, some studies have shown exercise to be as helpful as antidepressants in managing anxiety. The American Association of Cardiovascular and Pulmonary Rehabilitation, the AACVPR, recommends that all patients be screened for depression because of the high rate of anxiety and depression in these populations. Quantifying outcomes is important to measure success and achievement in a cardiopulmonary rehabilitation program. Outcomes are defined as, quote, a systematic examination of patient outcomes in relation to selected patient variables, end quote, i.e., age, sex, diagnosis, and interventions performed. The 3 main categories we will investigate are the biological physiological measures, the functional measures, and lastly, the HRQL measures. These tools will inform clinical decisions in designing a treatment plan and measure success within the plan. In understanding the various tests that can be given to measure patient outcomes, the main question to answer is, are we seeing a clinically significant change, and am I able to measure that objectively with the tool I have chosen? There are many databases with tools to measure outcomes, i.e. Rehabilitation Measures database, but to choose the proper tool, Shearer suggests that 7 key elements be considered. They are, number 1, what is the intended population? In other words, what is the purpose of the test and what type of patient is it intended for, including the patient's age, characteristics, and disease characteristics? 2, how valid is the test? Is it the gold standard? Number 3, how reliable is the test? Reliability is a measure of the repeatability of a measure through evaluation of its test, retest capability, and consistency. It is usually defined in statistical terms. 4, how responsive or sensitive is the test to change? For example, if the patient has made improvements, are those improvements consistently and accurately quantified by the chosen outcome tool? 5, does the tool allow for minimal detectable change? The goal is to use and find outcome measures with low standard error measurements, low standard deviations, which allow for improved ability to measure change and less variability within the tool. And lastly, 6, does the tool allow for minimal changes in outcomes to be detected? This is called minimally clinically important difference, or MCID, and is expressed in percent change. The importance of measuring outcomes include accountability to improve clinical and management decisions for optimal care delivery, for research, and as incentives such as the Current Physician Quality Report Initiative, or PQRI. Assuring quality of care is of the utmost importance to payers such as Centers for Medicare and Medicaid Services, CMS, and regulatory bodies such as Joint Commission on the Accreditation of Healthcare Organizations, or JCAHO. The AACVPR requires cardiac and pulmonary rehabilitation programs to collect outcome measurements for certification. They have created an outpatient cardiac rehabilitation data registry whose purpose is to track patient outcomes and quality of services. It provides national outcomes data for benchmarking and highlights the benefits of cardiac rehabilitation. The AACVPR recommends an outcomes matrix which includes a risk factor profile, symptoms, hemodynamic status, functional capacity, exercise response, lipid levels, blood pressure, glycosylated hemoglobin or HbA1c or diabetes management, weight body mass index, physical activity, nutrition, psychosocial management, and smoking cessation. In addition to demographic data such as age, gender, race, marital status, primary and secondary diagnoses, surgeries, comorbidities, payer information, etc., and functional and quality of life information, the therapist should research the patient's biological physiological data, which is usually obtained from the chart review and medical history. Monitoring of data such as LDL, triglycerides, HDL, C-reactive protein, blood pressure, insulin sensitivity, weight and hemodynamic regulation at baseline and throughout the program can establish goals and reflect positive outcomes and high levels of care as a result of interventions. In addition, ankle brachial tests may be performed at baseline and during exercise to predict risk of CAD, hypertension, acute coronary syndrome, stroke, and overall mortality. Of special interest to the respiratory therapists are pulmonary function tests and their ability to predict severity of disease when used with CT scans of the lungs and mortality in COPD patients. Lastly, graded exercise stress tests can identify possible coronary disease or monitor the cardiac capabilities of individuals with multiple risk factors of CAD. Factors that may influence patient outcomes are diagnosis and severity of disease, clinical stability, comorbidities, physical functional status, age, sex, HRQLs, cultural, ethnic, and socioeconomic factors, beliefs and behaviors, attitudes and preferences, and psychological, cognitive, and psychosocial functioning. Patient outcomes are also influenced by cost of care, overall satisfaction with the program, and complications of their illness.